I'm happy to introduce our speaker today, Dr. Anobel Odisho. Dr. Anobel Odisho, he is a associate professor of urology at the University of California, San Francisco, and a clinical informaticist at the UCSF Center for Digital Health Innovation. He completed his medical training and urologic surgery residency at UCSF and a Society of Urologic Oncology Fellowship at the University of Washington before joining the UCSF faculty in 2017. His research focuses on clinical informatics and the development, implementation, and evaluation of digital health programs that extend telehealth into asynchronous automated patient care. He has developed an EHR integrated clinical trial screening platform for urologic oncology patients and oversees for the digital patient experience program. He has launched virtual care programs for patients undergoing prostate biopsy, lung transplant, patient home spirometry, remote monitoring, automated IBD symptom assessment and medication management, and COVID symptom self-triage. He has also published on recent trends in telehealth utilization and the impacts on health equity. Welcome, Dr. Odisho.
So thank you for having me. Thanks for that great intro, Caitlin. I'm one of the urologic oncologists here at UCSF. And aside from all the clinical and operative time, I spend about a third of my time at the Center for Digital Health Innovation, where I'm a clinical informaticist and I lead the virtual care programs. I'm probably one of the only one or maybe two urologists in the country that are also board certified in clinical informatics. So a little bit of a interesting hat. These are some disclosures. And before I get really deep into the program, I want to outline what the Center for Digital Health Innovation is at UCSF. We're a group of now almost 65 people, all working at CDHI, and really focusing on implementing and evaluating our virtual care and any sort of digital health tools for patients. Really focus on the patients and trying to make sure we can deliver scalable healthcare without borders or boundaries outside of our walls. We call it a click and mortar experience. And really trying to bring in, best of human and potentially artificial intelligence for the care solutions that we deliver. We publish papers. We have a lot of commercial relationships with industry partners, whether they're co-investing in technologies or licensing things that we've developed. And we have a lot of programs live at UCSF. So we talk a lot about healthcare digital transformation. And digital transformation usually goes through a couple phases. Some of you may remember waiting in the line at the bank, and some of you may remember Blockbuster and renting VHS tapes. That was the old analog world. The experience that we have now, where we bank on our phones or on any mobile device, and we have streaming services that customize content, constantly refreshing, really knowing and predicting what we may like. In the interim, though, going from analog to the personalized digital that we see, there's this era of what we call dumb digital, where it's kind of digital, but doesn't really take any advantage of the power of that technology. So, in healthcare, we're in that dumb digital phase. We use computers, we use electronic health records, but it's effectively, we took the old paper charts and just put them on the screen and haven't done too much more with them for now. We have a database developer who, I love, he said, I walk through the hospital and I see a lot of computers, but I don't see any computing happening. And so I think we really have an opportunity to take that next step in healthcare digital transformation. I want to give an example of a patient pathway and highlight how our current care experience, the current patient experience, is really episodic, it's reactive, it's quite inefficient, and it's not personalized at all. Now, this is a bladder cancer experience, and everyone has a little bit of a different journey, but as a generalized journey, you can see how a patient transitions between so many different phases of care, whether it's ambulatory, a procedure, an outpatient procedure, a major inpatient procedure. This is a patient that notices blood in her urine. So it takes her, a few phone calls to schedule an appointment with her primary care doctor. Now, finally, she gets in with a primary care doctor who, may order some imaging and refer her to urology. She comes to the urology clinic for what she thought was an H&P, and then finds out she's getting a cystoscopy that day. Doesn't really know much about the procedure, but agrees, gets her cystoscopies, has a bladder mass, then has an experience at the ambulatory surgical center where she has a come and go surgery for TURBT. Unfortunately, it's, she doesn't totally understand the recovery, maybe has some symptoms and calls in. She has to have another meeting to review PATH. And unfortunately, it's muscle invasive. So she's referred to the medical oncologist for neoadjuvant chemotherapy, a few more phone calls to get that scheduled. She finally starts her neoadjuvant chemo, and that's an experience at the infusion clinic. All the way through, you have terrible symptoms from systemic chemotherapy, and no one's really checking in with her proactively to evaluate her symptoms or patient report outcomes. Maybe she's having near the end of her infusions really bothersome nausea or pain, can't get a hold of anyone on the care team in a timely fashion, so she shows up in the ED to manage her symptoms. Then she's through this and she has this major inpatient cystectomy, maybe a 4 to 7 day hospital stay, and then post-operatively again she's kind of out in the wind. Maybe she has a follow-up visit, but in between she maybe forgets some of her post-procedural instructions, maybe isn't hydrating, shows up to the ED again, then gets readmitted. And then finally, she's through this entire, we put her through the ringer, and now she has to follow up at a really frequent cadence to make sure she's not having a recurrence. Now, this is a similar experience in many of the diseases that we treat. Even in benign disease, you can take out maybe the infusions, but this similar kind of episodic experience where at every point a patient can fall through the cracks. What we aim for is to develop virtual care pathways so that we can deliver healthcare outside of this in-person, face-to-face interaction. And there's a continuum of what virtual care really is. On the far left, we have our in-person care, which is synchronous and high cost. Now, and then as you move to the right, you start slowly getting towards lower cost or asynchronous care. We've all now done telemedicine. And I love virtual visits. About 80% of my practice are virtual visits, but it's not fundamentally different than the kind of in-person care we deliver. We have the same meeting with a patient. We can't do a physical exam, and now we put a screen in between us. There are e-visits or virtual check-ins, and those are where we check in on patients for symptoms outside of a scheduled encounter. There's remote patient monitoring, and all the way to the right, this automated virtual care where patients are on a pathway. There's a system checking in with them and actually triaging the frequency of their care and triaging them to specific dispositions. Now, I am the biggest technologist you can imagine. I love anything that plugs in or beeps. But really, at the end of the day, technology in care delivery does not lead to or guarantee success. All of us have experienced this with the rollout of our EMRs in our practices. And so then someone thinks, well, that's fine. We have a lot of technology, but we also, let's just pair that with good intentions. Argue that this is going to improve patient outcomes. We argue that patients are going to like this. We say this is just the right thing to do. Unfortunately, even those two things together don't necessarily lead to success. And what we really need to aim for is building a system that integrates technology into our existing care workflows, whether it's provider workflows, nursing workflows, or patient experience in their care delivery process. And I think that's how we can get to a successful virtual care implementation. So at CDH, a process where we work in multiple rapid iterations before we roll out a large program. So we identify we identify our organizational objectives, meet with patients, understand what the care needs there are. We have user experience and user research designers. We develop rapid low fidelity iterations and then release what we call a minimum viable product, right? Or we also say the minimum viable learning. What's the smallest thing that we can get out there, run a short experiment, learn, iterate the program, and then keep going. We then work to improve, and then once we've stabilized, we think we're achieving the outcomes that we aimed for, then we go out more broadly for a patient cohort. I'm just going to outline some of the overall programs that we have going to give you a sense of the breadth of the possibility. For acute symptom triage, where patients are reaching out to us with a new symptom, we were fortunate enough to have built a flu symptom checker in 2019. And so March of 2020 rolled around, we were able to quickly pivot that to be a COVID symptom checker, had that up and running in just a few weeks, where patients were able to submit symptoms through MyChart. So far, that's been used about 102,000 times by 46,000 unique patients. And through that, we can transition them to unique dispositions, whether it's prescriptions, testing, or having them come in. And has significant savings for how much time that would have taken a provider to do all that triage. Around peri-procedural care, we have programs in patients undergoing prostate biopsy, orthopedic surgery, interventional cardiology, valve replacement, thoracic oncology, and vascular surgery. And in these programs, we've had over 20,000 patients go through the various care pathways here. And then a separate, peri-procedural is you have a very specific episode of care. So there's a pre, a peri, and a post. For chronic care, this is, these conditions don't necessarily go away. And so you have to design and think about a totally different virtual care implementation. And here we have programs in patients that are recovering from lung transplant, that are ready or anticipating a kidney transplant, for living organ donors, hypertension, cancer patients getting infusional therapy at our infusion centers, and patients with IBD. And if you are wondering, yes, it is a little bit weird to me that as a urologist, I'm involved in all these different programs. Sometimes I take off my urology hat and put on my informaticist hat. I think I'm the only urologist that had a abstract at Digestive Diseases Week and the International Society for Heart and Lung Transplant. So we're multidisciplinary in our work. I'd like to go into a few of our programs to highlight some key learnings. And one that we'll start with, which is going to be kind of the most hit close to home for this audience, is our prostate biopsy program. Now, we do a lot of prostate biopsies. We're a high volume center. We do somewhere between 80 to 100 prostate biopsies a month at our cancer center. And a few things that we realized is, one, there's a lot of patient education required to get someone to a biopsy safely. Especially if it's their first biopsy. So our nursing staff were spending a lot of time communicating with patients, answering their questions, and getting them prepped. We also had a reasonable and unexpectedly high rate of cancellations, particularly same-day procedure cancellations. And a same-day procedure cancellation, I think that's terrible for everyone involved. The patient's taken time off from work or from their family, has driven here and kind of has mentally prepared themselves for this uncomfortable procedure. From the clinic side, now you have an hour-long procedure slot that goes underutilized. And so we wanted to see what we could do to try to ameliorate these two factors. We launched a primarily text message-based program. So when patients are scheduled for their biopsy, they're automatically enrolled in this program. They receive text messages before and after their biopsy, kind of 14 days before and a few days after. And if they don't have a mobile phone, then the system automatically, or their phone number bounces, then it automatically switches to email. And they get these messages, they click the link, and it takes them to a secured environment that's linked to their identity. So they don't need to log in, they don't need to know a password, and it just opens this web-based symptom survey system with educational content. The key is we really try to aim the reminders and the information for when it's most important for them. And if there's any concerning result or anything abnormal, we worked with our nurse manager in our clinical practice to actually receive those alerts so they could act on them. So every morning they'd get a report on who had concerning issues that they needed to address that day. So for example, on 7 days before the biopsy, if they're taking blood thinners, they're reminded, hey, were you counseled to stop your blood thinners? And now's the time to do that. And if they haven't stopped their blood thinners, then the nurse can contact them and talk to them and say, hey, what's going on? The day before the procedure, they're reminded to start their antibiotics. And then afterwards, we check on symptoms. Overall, we saw reasonable engagement between 45 to 73% in terms of patients opening the links and following the content. And we compared a 3-month pre-intervention period, had a 1-month washout, and then a 3-month post-intervention period. And during that time, comparing about 600 appointments before and 400 appointments after, we saw that same-day cancellations went down from 3.8 to 0.5%. There was also a decreased rate of cancellations within 7 days. And so that lets you more effectively fill that spot, 7 and 14 days. Now, fortunately, there were no increased messages from the patient to the provider, right? So we were monitoring in-basket volumes and phone call logs. But there were an increased number of pre-procedure phone calls, primarily outgoing to the patient to address issues that came up. So we took that information and we said, okay, this is having a significant impact. We are going to keep this program going. And once we had accrued enough patients, we went back and looked at what are the predictors of someone engaging with the program? Because the common feedback that you hear is, oh, well, maybe older patients aren't going to be as excited to do this, or they're going to have difficulty with their phones. Maybe there are going to be some disparities, both in race, ethnicity, or language, or by payer. And we found is age was actually not an issue at all. When we think of someone who's 65 today, they've probably had a smartphone for 10 to 15 years at this point. So it's not totally novel technology. We didn't see any differences in race or ethnicity in terms of engagement once they were enrolled in the program. We did see non-English speakers were less likely to engage, and that's because when we rolled out the program, it was only available in English. So that's understandable. And single men were less likely to engage. There are no other differences in whether someone came from a rural or urban area, or the socioeconomic status as their neighborhood score as a proxy for socioeconomic status or payer. We also saw that there was no difference in patients who had had a prior biopsy or not engaging with the program. So they still found some of the educational content useful. And since then, we've just kept the program going. We continue to monitor our results carefully. We've had about 4,300, 4,400 patients go through this program. And it's a pretty lightweight program, but it doesn't need to be a heavy program to be effective in terms of improving specific outcomes. I think the key is having practice buy-in and making those workflow changes. So we really engage with our clinic manager early and engage with our nurses to help us, design the content for some of the questions they get the most often. And by targeting some of these operational metrics, we're able to get practice and enterprise buy-in to continue to pay for the program and keep it going. And then we monitor for disparities over time. Now that's an example of a light peri-procedural program on, off, with some short-term operational outcomes. We also launched a program for patients undergoing lung transplant and recovering recipients of lung transplant. Now, the clinical problem here is a little bit different. We have about 550 living lung transplant recipients, and the primary concern is chronic rejection, which has a high mortality rate at 5 years. Unfortunately, monitoring for rejection takes really frequent hospital-based pulmonary function testing. So patients have to come into the lab every 3 months. And you can imagine a lung transplant is a quaternary care experience. We have patients from all over the state of California coming here for this. And so that can be a major issue for them. So we launched and designed a program where patients have a Bluetooth-enabled home spirometer. They blow into this thing. We get their spirometry results. We engage with them through a virtual care chat. We collect the results. We monitor them. We check patient-reported outcomes. And if there's something concerning, then the clinicians get notified. So we put together this kit, this home spirometer with our UCSF guide, and patients get enrolled into this virtual care chat. This is what you can see in the middle, what it looks like on their mobile phone, or if they open it up on their desktop. Now, it's not a true chat, right? There's no natural language. It's a little bit of a glorified question and answer, where they're presented with very specific things that they can either click on to respond with or submit numerical values. And here you can see this process of early testing, modification, and growth. On the right, you can see our enrollment chart. You can see it's very uneven, and that's by design. So at the beginning of the program, we just enrolled 5 patients. We interviewed them, we met with them very closely, understood if the program was working, what their uses were. And then once we were comfortable with the program stability, there were no major bugs, we then allowed patients to self-enroll. So we would have town halls engaging all the lung transplant patients and allowing them to opt in. This is how you get your early adopters, okay? So you can see this slow, steady trickle of patients kind of an uptick after each town hall and then a slow, steady trickle over time. And then once we felt the program was much more stable and ready to go mainstream, we then enrolled all the rest of our patients. So you see this big spike. And the current program now, you can see a slow, steady trickle as new patients are receiving their lung transplant. We've integrated with the EHR, so you can place an order in the EHR for a lung transplant virtual chat, sign that order, and the patients get enrolled and start getting messages. And we've included that order in the discharge order set after a patient receives their lung transplant. Overall, of about 560 patients that have enrolled, about 3/4 have engaged with the chat and submitted some remote monitoring data at least once. But just doing this is not enough. This is a much heavier clinical program. So we wanted to see, are these values reasonable? Are these home spirometry results comparable at all to in-lab PFTs? And so we compared that. There was actually very close correlation between their in-lab spirometry and their home spirometry results. The R-squared for this was like 0.94. And we also identified in the course of this study period, there were 68 patients that unfortunately had chronic lung allograft dysfunction, but 1/3 of those of new onset and progression was detected first with their home spirometry. So when a patient has an over 10% decline in function, a notification gets sent to the provider's EHR inbox. Okay, so one of the philosophies of this of any patient engagement tool that we have is we never ask a question unless we act on the response. The last thing we want is a patient's response to go into some black box and no one ever check in with them. So in this program, when their FEV1 drops by more than 10%, the program checks in with them automatically more frequently. They go from a weekly cadence to a daily cadence. But then a notification is also sent to the EHR in-basket, which tells the provider, here's their baseline, here's their most recent result, here are their last 5 results, okay? And the providers can then, either themselves or their staff, call in with the patient. So tight integration into workflow is really important. We also have to have really close partnership with our clinicians and our subject matter experts because we are now generating more work for them, right? We also had to work with them to really define what the alert thresholds were, what generates a red alert. And we had a lot of learnings about this. Early in the program, if a patient said they were fatigued, our provider said, hey, if they're fatigued, we want to know about this. But, it was also the middle of the pandemic and everybody is fatigued. So that was generating about 50 alerts a day. So we decided, the providers were overwhelmed with their alerts. And they looked back and said, this is not a very specific question. So that no longer generates a red alert. We also integrated the data into the EHR. So the home spirometry values the patients enter actually every day get loaded into the EHR, and these reports get generated in Epic, which is what we use for the providers to see during the course of routine clinical care. They don't need to log into a separate dashboard or know a new password or get familiarized with a different system. And so they can see how long the patient's been in the program, how many FEV1s they've submitted, their most recent values and their trends, and they can put this into their note, okay? I'll tell you, the patients love this because they love seeing where they are, and the providers really appreciated having this data at hand. Now imagine going from a situation in which a patient is submitting pulmonary function testing once every 3 months, where you don't really have a close understanding of their trends, to now they're doing it maybe 4 times a month. And you have really granular data. We took this data back to the practice, and they really made this innovation without me suggesting anything because I don't know how to take care of patients that have had lung transplants. I don't know what's appropriate or not. But they saw that, look, the home pulmonary function testing is accurate. We can see the data and use it in clinical care. We get alerted when patients aren't doing well, and we are identifying allograft dysfunction earlier. And so they decided to eliminate routine in-person visits. During the course of the first 2 years after transplant, they have a very intense follow-up program. And so, they have dozens of visits. 6 of these, they were able to replace with just a video visit and home spirometry, which is a huge win for patients because they don't have to travel as far. And it also opens up capacity in the practice for seeing new patients. Now, we also did a virtual care program for patients with IBD. And this is a little bit of a different use case here because we're not, giving them spirometers. We're not checking their any remote patient data in terms of monitoring. But it's also, unfortunately, a lifelong condition. We have about 2,500 patients at UCSF that are treated for IBD each year. And fundamentally, what we need to do is detect and treat a flare. Okay. And in order to do this, it requires frequent in-person or video visits to assess their well-being. This is really time intensive. And, it really, it fills up the clinic, especially for patients that are doing totally fine. And you can imagine this example for a lot of the patients in urology. In each subdivision of urology, whether it's benign or oncology, stones, there's certain patients that you need to keep following up with, you need to keep surveilling them, but many of them are just doing fine. Okay. And so how do we kind of decant some of that volume? Historically, a lot of practices have decanted that to APPs, right? But that's not really fundamentally changing how we approach this treatment problem. So we thought is, can home patient-reported outcome assessments actually be an accurate replacement for some of the routine in-person visits? So similarly, we launched an IBD care chat, and patients receive some text information. The providers in the practice recorded videos the patients can watch on their device in the chat itself. And then we ask them symptom questions. Now, these are meant to be a little bit more conversational, but underneath, these actually map directly to standardized, validated PRO symptom surveys in IBD. So this is the type of PROs that are often used in all the IBD research studies. And so the providers are comfortable with them, they know how to interpret the results, and they know how to act on them. So patients are getting these symptom surveys. They get them periodically. Now you wonder, how often do you have to check someone with IBD? In lung transplant, we're checking them weekly at first and then graduating them to monthly if they're stable. In IBD, we started a monthly cadence. And after patients show us that they're in remission and their symptoms are stable, then we actually space that out to a Q6-month cadence so as to not bother them. But if their symptoms recur or they have a flare, then they get dropped down quickly to a weekly cadence and the team gets notified. We can see we've enrolled about 3,400 patients in an IBD care chat program, and 1,400 of them have engaged. The overall engagement is 41%, so lower than the lung transplant patients. And I think this is a key learning, which is each clinical condition has different patient activation energy. It's really dependent on the severity of the condition and the severity of their symptoms. Lung transplant patients, they went from I can't breathe to being able to have some semblance of a normal life. They will do anything for their providers and for the practice. IBD patients, on the other hand, a majority of them are actually doing just fine. It's a relatively younger cohort. The average age is in their 40s. They're professionals. Our patient population is reasonably, well educated, And so here they are, they're doing fine, and they keep getting these text messages. So our engagement's a little bit lower here. We actually have a higher rate of patients opting out from this than we do from some of our other programs. So we thought to ourselves, why, what can we do to provide more value for these patients and really keep them engaged? These virtual care programs, we look at them from the operational lens, from, what impact will this have on our appointment capacity, billing, our ability to see new patients. The patients don't care about that. And, one of the real epiphanies for me came from speaking to one of our faculty members. They were they were internal medicine faculty, and I was talking to them about something totally unrelated. They knew what I was working on, and they said, I have IBD, and I get my care here, and I get all these text messages, but like I'm fine, so I just ignore them. And so we actually had our user experience designers meet with a cohort of 6 patients that had been in the chat but stopped using it, and did structured interviews to understand why, and did hour-long structured interviews with them, and then started pulling in some themes. We've done similar things for our lung transplant patients as well, to really understand what the patient's needs are. And the recurring theme was, I'm doing fine, I don't need this. So we thought, we ask patients to submit PROs all the time across lots of clinical conditions, but we don't really make sure patients see value from this. Sometimes they feel like they're just doing it for our sake, or just submitting, just being data entry folks. And so we thought, okay, what if for the patients that are doing fine, who don't actually need intervention, we can potentially help them refill their medications? Because of insurance requirements, even the patients that are doing fine need to have a check-in visit every 6 months to document that their symptoms are under control, so that they can get their medications renewed. And so we thought, what if we automate that process? We know how they're doing because we're evaluating them. Even though it's asynchronous, it's through a remote chat, it's not an in-person face-to-face encounter, we are still evaluating them. So we worked with our billing and our compliance folks to make sure we checked all the right boxes. And we created a workflow in which we can automatically create documentation in the chart for the patient on behalf of the provider, which integrates data from Epic. So their last visit, the provider they're seeing, the medications they're taking. And then we say, we're evaluating the patient, and we bring in data from the patient report outcomes. So they put the data into this third-party chat. It actually gets integrated and written into Epic, so our providers can use it into routine care. They can create dot phrases. They can use it in their clinic notes. But we create this documentation that says the patient is being evaluated. And then the nursing staff submit this documentation for medication refills. We went through the process and had this audited and confirmed that patients were able to get their medications authorized and refilled. And then we asked them, hey, you're doing just great. Here's your medication refill. Do you want to come in for a visit, or do you want to just check in 6 months later? And an overwhelming majority of patients that have engaged in this program that have gotten to that point say, great, we'll skip our routine follow-up visit. And so that creates capacity for IBD practice to do what they do best and see new patients, bring in complex patients for care. The other thing that's really important is, monitoring the results of these programs. We want to monitor patient engagement, patient satisfaction, and also the impact that we're having on providers and their workflows. Because you can imagine getting additional notifications to your in-basket is not fun. We built a dashboard tracking overall program engagement. You saw a snapshot of this for the IBD program. Here, this is across all our programs. We can see how long a patient's been in our chats, what patients are opting out and why, how many were enrolling over time, how they're engaging, how many chats they're doing. And for each of those, we can dig into a per program level. And so we do this with each program with the clinical subject matter experts and our clinical champions, where we do it monthly. We check in with them and say, hey, how are things going? This is what we're seeing in terms of engagement. We break this down by age, by ethnicity, by language, to really understand if there are gaps in the virtual care that we're delivering, because there definitely is a high risk of actually potentially increasing disparities with some of these virtual care programs. If patients are non-English speaking, if they don't have high health literacy or high technological literacy or capability. The other thing that's really important is to continue to monitor the patient experience. So at the end of each chat, patients are asked a simple question: did you find this chat useful? 1 to 10 score. And we calculate a net promoter score over time and by program. Okay. And we can see, our lung transplant patients have some of the highest net promoter scores. They love the program. In our IBD program, which is one of our larger programs, not so much, right? Which is why we try to dig into why patients aren't engaging and trying to provide value for patients and hopefully increase that net promoter score. So we review this periodically with our clinical leaders as well and say, this is what your patients think about the program. For a small subset of patients, we randomly select them to actually do a much longer survey. And so a small subset of patients get asked after that simple question if they'd like to participate in an additional survey, where we ask them in more detail if they thought the chat was useful, if it met their needs, if it met their expectations for what they wanted from their care team, if it was easy to use and user-friendly, if there are any inconsistencies in the content that we're providing compared to what their providers are telling them, and if they were able to use this successfully. And then we dig in within each program to say, look, the lung transplant program maybe is actually not so user-friendly. And so when we did research with individual patients, we learned a lot of the difficulties that they were having with the spirometers, right? Getting the Bluetooth spirometer paired to their phones, knowing how to blow into the device. Something as simple as, again, I as a urologist would never have known. And even our clinical subject matter, our lung transplant physicians didn't appreciate until patients told us. They said, okay, you give me the spirometer and I have to blow into it, but I have to look up while I blow into it, but then I also have to hold my phone so I can see the results. And sometimes I'm looking down and I can't expand my lungs as much. And I get these numbers that they make me feel sad, and so I have to keep doing it. And so a lot of learnings from close monitoring and following up with patients. The other thing that's really important is the in-basket. Every provider here knows the in-basket is, the bane of your EHR experience, right? Leads to a lot of additional unreimbursed work burden, a lot of after-hours care, a lot of care outside of clinic, just managing message after message, and it's a significant contributor to burnout. Nationwide, the amount of in-basket volumes have increased. At UCSF, they have increased dramatically, and there are efforts across all the departments and divisions to try to understand why there's so much in-basket message volume, whether they're results or messages from patients, and how do we better triage and decrease that. I'm very acutely aware that our virtual care programs are actually adding to this in-basket burden. We are creating new alerts, and we're contributing to alert fatigue. But not all alerts are bad alerts. And so, again, we partner very closely with our providers. We monitor the results over time. We feed that back to them and really try to understand how it's affecting their workflow. So for each program, we can dig in and see how many messages to the in-basket we're generating on a monthly basis. And we define this metric as a relevant alert. What's a relevant in-basket alert? I hypothesized that if you get an alert in your in-basket and you just mark it as done or complete or delete it, but you didn't take any other action in the EHR, that was probably not a very useful alert. That was probably a false alert or a low sensitivity or specificity alert. So what we do is after each alert comes in, we retrospectively, we look through the EHR, not by hand, fortunately. And for the provider that marked an alert as done, we then look and see what other actions that provider took in that specific patient's chart for the next 48 hours. And if you did something in the patient's chart after or around the time you marked that message as done, we infer that that was probably a relevant alert. So about a third of the alerts that we send after or while the provider interacts with that in-basket message, they do something. Whether they order labs or procedures, sometimes they order medication, sometimes they create notes and documentation or start new encounters. And so then we take that back to the providers and we say, look, yes, we set you an in-basket alert, but after you got this in-basket alert, in lung transplant, you ordered a chest CT, you ordered a bronch, and you scheduled the patient for a bronch. Or for this other patient, you ordered a Prograph level and a bunch of labs. So yes, the in-basket did generate some more work for you, but it seems like this patient was having a decline in their lung function and they needed your help. And by doing these things and launching this program, we're actually identifying a third of the chronic lung allograft dysfunction potentially earlier. And so it's this constant feedback that keeps the providers engaged and allows them to tolerate the in-basket alerts that we send. So what could be the future state of a virtual care program? We're really trying to orchestrate care. And from the patient's perspective, we want to personalize the care that they get. We want to check in with them frequently when they're not doing well. We want to check in frequently when we know they're likely to have symptoms. So let's say right after their chemotherapy infusion, we check on day 3. We also want to act on the information they give us. So provide value to them. Maybe we follow up with them in person. Maybe we order labs and medications if they're not doing well. Maybe we let them de-escalate their care if they're doing just fine. From the practice perspective, what's really kept us from doing this at scale is just how much, staff effort it takes. You could do this manually and call all your 2,500 IBD patients and call them all once a month and go through a symptom survey with them. But we all know that that's not feasible or scalable. So how can we provide our care team with the tools for them to actually orchestrate these personalized care experiences at scale? So this poor lady that presented with hematuria, maybe in a future state, when she first notices the blood in her urine, she can actually do a self-directed symptom screen. And that can dispo her to a specific output. And that might just be, hey, we got to do a video visit today and understand what's happening. And she can get a same-day video visit with a primary care physician. Okay, that can be a nurse practitioner, APP. We follow up with them, and based on that experience, she could maybe get an earlier referral to a urologist. Okay, and instead of having to call the urologist, we proactively reach out and help her schedule automatically. Okay, help her schedule through a mobile interface where she sees the available appointments and can quickly pick one. We then, do her cystoscopy. She's had some education in advance, so she knows what to expect. We pull this care forward and maybe more quickly get her into the ambulatory surgery center for her TURBT. Before the procedure, she gets some education and prep, getting her ready for the procedure. And then afterwards, we automatically follow up with her so we can identify if she's not doing well. Maybe that gets her into the medical oncologist a little bit quicker. She gets her chemo infusions at the infusion center. A lot of the education around expectations for what a what a patient can expect, or how do you proactively self-manage your symptoms, we can send her that information in advance. After the chemo infusion, we check in on patient-reported outcomes, automatically on days, 2, 5, and 7, when they may be the most likely to have chemo-related symptoms. And if someone is having concerning symptoms, because we're proactively engaging with them, maybe we catch those symptoms earlier. And we can then either do a same-day visit or have her come to our cancer acute care clinic instead of going to the emergency department and potentially getting admitted for a symptom exacerbation that we could have identified earlier. She then goes through this major inpatient surgery. And we're very lucky for all the work that people have done in ERAS pathways to try to shorten the hospital stay for cystectomy. But there are also a lot of additional tools that we can bring to bear to maybe get that patient out the same day or sooner, not same day from surgery, but as early as they would from an ERAS pathway, but then augment that with additional virtual care tools so they're not out at home with no one to watch them. So symptom monitoring, we have systems in place where we can actually send phlebotomists to their home to get labs or do hydration at home, and really kind of engage with them outside of this face-to-face provider experience. And then after they've reviewed their path and we set up their follow-up regimen, what can we do to automate that? Think of the situation of a post-prostatectomy patient getting their PSAs checked. If their urinary and sexual function is stable and at the point where they're not seeing significant improvement, or they've already recovered, and now you just need to check their PSA every 3 to 6 months, as long as it's fine, there's no need for them to drive into clinic or even have a video visit to say, hey, your PSA is fine. We can algorithmically say, PSA undetectable, great, follow up in 6 months, here's another lab slip, and just automate that process so that patients can have more of their time back and that we can open up capacity in our practices for new patients. So we can build this kind of really proactive and fluid care experience where even though patients are experiencing different physical aspects of our care, whether it's ambulatory or the clinic, ambulatory surgery center, OR, inpatient admission, they have a unified digital experience from the beginning of their care journey all the way through the end, where they know we're just a touch away, but we're able to automate a lot of that high touch care. And like I said, I'm a huge technologist. I love technology, but in all the virtual care programs that we do, yes, we have developers, we have solutions architects, we have QA engineers. Technology, though, is the smallest piece of what we do. It really is. And the real impact for the drivers for having a successful virtual care program are workflows, change management, and patient value. So we have to understand how people work. And that's something as simple as asking them or sitting in clinic with them and just watching them, looking over their shoulder or having them screen share as they go through the tasks they need to do to deliver care. We really try to integrate with existing workflows wherever we can. You can't pull people into a different system and expect that change to stick. We also have to integrate data. So whether we're pushing as much information that we know about the patient to this third-party platform, so that we're not asking patients questions that we should know the answers to. And also pulling their data back into the EHR so providers can use it during routine clinical care. We also have to work on improving provider efficiency because nobody wants to work dumber or harder. And the workflow piece is not just for providers, but it's patients and understanding the patient workflow and how they manage their care. A lot of this requires close change management. For some of our programs, we didn't approach this. Some of our early learnings, we didn't approach the staff with the right amount of empathy or understanding of their existing kind of care processes, and we were met with a lot of resistance. Really, we have to build close operational partnerships. That's with the clinic leadership, that's with the practice leadership, the physicians, and we really have physician champions who go up there and they believe in the program. They'll spend a bunch of time and they go and discuss with their colleagues. I'll tell you, in our lung transplant program, Steve Hayes, one of our lung transplant, our program director, he managed all the in-basket alerts for all 500 patients for almost a year. He said, look, I know we're doing a lot of development. I want to make sure this is right before I push these alerts onto my colleagues and our providers, because if it doesn't work, they're going to burn out, they're not going to like it, and we're going to have to shut down the program. And so he took that burden on and then went out to the provider and said, he was able to say with authenticity, hey, I've been doing this for a year for all 500 patients, and it's not as bad as you think it's going to be. Okay. You also need to speak health system leader language, which is, FTEs per RBU, operational efficiency, clinic slot utilization, all these things that get the people that write the checks and support the programs to keep us going. And most importantly is, we really at every step focus on patients and improve their experience. We're really not trying to burden them with an additional tool to use if they're not going to get value from it. They're dealing with complex medical conditions, and the last thing they want to think about is a new platform or app. So we really have to make sure they're seeing some value from this. And we want to make it easier for patients to get high quality care and get into our systems, and really provide feedback to patients to reward the engagement. So they love seeing the results. And I think if you do all those things, we can have really an effective virtual care program that drives patient value. And so kind of with that, I'll stop and take some questions if there are any.
Thank you so much. What a great talk. Really amazing work. We've tried doing similar things here across a variety of different specialties, and really kind of a fraction of what you've been able to accomplish. And it's really, really hard work. A quick question. Have you, I think there's a lot of interest in the idea of artificial intelligence and, hey, can we mine the electronic medical record and see how patients were treated and then be able to guide future treatment based on that? I think one of the challenges there is sometimes we provide care that's the existing care may not be perfect, right? And there's a lot of care that's not guidelines concordant. Have you done any work to be able to try to influence the quality of care that's being delivered? For instance, if a patient with non-muscle invasive bladder cancer has their third course of induction BCG ordered in a 12-month period of time, is there some type of a hard stop, a flag, a review that's triggered? Can that type of work be done? And if so, what kind of work have you done?
I'm a huge proponent of trying to bring in any sort of machine intelligence to what we do. But I think that we sometimes bias towards trying to solve some of the hardest problems first. There's this great paper, and it's called Hard for Humans, Hard for Machines, right? What you're describing, these clinical scenarios, I bet if you had a panel at SUO, you'd have 5 different opinions on what to do. So how do we actually, what's the gold standard? A lot of AI tools, I'm sure you've heard of, trying to predict sepsis, which is a very difficult clinical scenario. What I think we can actually really make a lot of progress on is the dumb stuff. Okay, the really boring operational things that everyone agrees this needs to happen. And we can use artificial intelligence to expedite that. So we have a program for automating referrals. And so when a referral comes in, we get scanned documents, which are terrible. And so we use optical character recognition and AI to then extract information from that referral and pre-populate the referral object in the EHR, saving tons of time for staff typing from faxes to something else. I think the real opportunity in AI right now is automating the dumb, low value stuff that we all agree on, and then buying us more time to sit around in a room and think about these complex patients and have those discussions around, with shared decision making for, do we do reinduction BCG, or is this time for an early cystectomy, or what's the right thing to do here? I think that's where I focus most of my energies.
Great, thank you.
Well, I will say it takes a big team. Our CDHI team, they're 65 people, but also lots of people at the practice level to really be engaged in a lot of these programs. So it's certainly not fast, but I think you can have pretty significant patient impact. And
Hey.
you have tons of opportunities in urology. Please.
Hi, this is Leslie Ricky. Can you hear me?
Yes.
Thank you. That was really fascinating. And I think there's so much opportunity I appreciate the balance between improving care, but also improving your stakeholders at all levels to make sure you're creating capacity and not burden, and balancing all that out. I love the idea of the kind of deep qualitative work to understand the user experience. And so I think it's all really wonderful. One of my questions is, and I apologize, I missed the very beginning. Who is your primary partner in this? I know it's a team, but when you first got started in this, how did you start leapfrogging around to find your people?
Yeah. One of the first things I started with was in prostate biopsy, where, I was closest to our clinic. I do them. And I basically just sat with our chair and said, hey, we want to do this. Do I have your support? And he said, fine, you got 6 months of runway and let's see what we can get. The other practices, we try to really communicate widely throughout the enterprise as to what we do. There's a newsletter that we communicate our findings and some of the programs that we have. And we wait a little bit, especially in the early programs, for people to reach out to us and say, hey, I have this problem and this is what we could potentially do. We really have to have that clinical champion. So the lung practice actually came to us and said, we'd like to do this. It's COVID. I got to get spirometers in the hands of my patients. We're just going to buy them and send them out and ask questions later, help us put this together. So really, it's been around waiting for inbounds, telling the story to get people's wheels turning, and then making sure that we have a good operational and value story around that. Because unfortunately, no matter, if the baseline is that we should be improving care, right? Improving care, quality, and experience. But just saying that and then going to an operational leader and say, can you fund my program? They're going to say, well, it's great that you're improving care, but gosh, I got to buy the CT scanner and there's this other thing that we got to buy. And how am I going to fund all that staff? So we really have to have that value story for the health system leadership.
Thank you.
One last question about sustainability. I mean, one of the challenges we've had with some of our, care redesign is revisiting it in 3 months or 6 months in a year, maintaining engagement, and also making sure that the way we're doing it is still up to date clinically. For instance, we have what we call a care signature program around non-muscle invasive bladder cancer that lays out a Yale standard for how patients are supposed to be cared for. Now you have a new drug that's FDA approved, and how do you get the engagement again to go back and rebuild a platform? So how have you been able to do to kind of maintain and sustain your gains?
Do you mean the engagement with the vendors and the kind of who built it, or the clinical leaders?
The clinical leaders, the patients. So for instance, if you decided what patient reported outcome metrics your seeking for your patients, or you have a care pathway for them, how do you make sure that a year from now you're still doing current care?
Yeah. So, in that, when we're in kind of the acute program phase where we're designing it, I was meeting with our lung transplant doc, Steve Hayes, I want to say like daily, weekly, super tight. And then once the program gets stabilized, we space those out. And so now we have a monthly cadence. We meet once a month. We review the engagement results. We review the in-basket results, and we say, what's your experience like? What are you hearing from your faculty? What changes do we need to make? So just kind of keep that persistent relationship. Maybe you space that out to every 3 months, but things change frequently enough so that we kind of keep that persistent engagement.
Great.
So,
Hi, Dinesh Singh here. We have time for a question.
Yeah, please.
I to echo what Dr. Ricky said, I applaud all of your efforts because it helps from the economic standpoint of more productivity for patients not wasting time going to work and not coming to doctor's office, patient ease of life and satisfaction, doctors' ease of life, and being able to get home to have dinner with your kids and not go through your epic inbox at the end of the day. So many things. The one thing that I think is critical for buy-in to occur with this, or to have systems in place that I didn't hear about for it to occur, is the legal system. And I'll tell you of a case that I know of that was in Philadelphia a couple years ago. Patient came in, pain, 4mm distal ureteral stone, ER sees them, no urologist, ultrasound, stone, and they also see a bladder mass. They give the patient discharge works, they follow up with the urologist. Patient, I think, even signed the discharge piece. I don't remember that actually or not. And patient's pain goes away, doesn't follow up with the urologist, goes by 5 years, has bladder cancer, has a cystectomy, is actually NED, goes to trial, and a verdict, even though NED, for $10 million. So it's slightly different than what you're talking about, but it is kind of the idea of onus on the patient, responsibility on the patient. And if the legal system doesn't support that, then that's a problem.
Yeah, I think you bring up a really important point. We try to have safeguards in whenever there's a concerning result. We notify the patient, call us, but we also notify the staff, contact the patient for this finding. We met we met early and often with we call our PLR, the privacy, legal, and risk teams for these patient engagement platforms. And I think we're fortunate in that our risk management team is quite progressive. And, they basically said to us, they're like, look, the train has left the station. These platforms are out there and people are using them. And at the end of the day, we're not risk elimination, we're risk management. So we have to really understand, make sure that we're doing this in as safe as a way as possible. And so we had their buy-in relatively early on. But you're totally right in that there is, these things are not risk-free.
Well, let me ask you, do you know of a case precedent in the opposite way, that it went to trial, or there was a judgment and it favored the healthcare or doctor because the patient was clearly told something but didn't do it?
I am not familiar. But again, we pair that with when we tell patients to do something, we also tell the staff to check in with them. So we try to get it from both sides. But I'm not familiar with any legal precedent around that.
All right, I think we're over time. Thank you so much, Dr. Odisho, for talking to us today. It was a fantastic talk.
Thank you all for having me. Happy to chat whenever. Feel free to drop me a line if anyone has any questions or wants to chat.
Have a great weekend.
Thank
Thanks
you
so
all.
much. Great work.